All right. Thank you for confirming the slides. I think we'll start, and please feel welcome to use the chat for any questions. I've been asked to speak about adult epilepsy, and this is a series of many talks on epilepsy within this wonderful expo. Some of what I'm going to say may be duplicative to other lectures, but I'm assuming that people attending the expo are not going to every lecture, and so I'll be focusing my perspective toward adult epilepsy with some references to epilepsy in general that may be relevant and spill over to other lectures. The treatment of epilepsy or providing care for epilepsy has certain challenges, aspects that are typically present and can be rather difficult for both the patient and the clinician. And I've just summarized them here, and I'll be using this as a framework as we go through the slides. But the point in which to diagnose epilepsy is not always straightforward. We're talking about this in more detail, and the question that follows this immediately is whether to start treatment and when that should be. And then the question can become how long to treat, because a person may become seizure-free. And then the question will be whether treatment is still necessary. Choosing which medication to use can be challenging, and even to identification of when seizures occur can introduce a challenge to ongoing management. And it's not just identifying seizures, it's also keeping track of seizures and providing data about seizures that can be useful for ongoing treatment decisions. And then with epilepsy, additional elements can be present that can complicate one's life. And so that's the additional counseling that becomes important. And then ultimately, for a person who's not seizure-free on medications, the question becomes when and which non-pharmacologic treatment to be used. Pharmacotherapy or medications are the first line. We have many excellent medications, but medications are not the only possible treatment. So I'm going to take a step back and just clarify some terminology, because the differentiation between seizures and epilepsy is not always obvious to people, and that ultimately seizures are episodes, seizures are events. Seizures have a very specific start and stop, which is usually a matter of minutes. And seizures represent a brain state with dysfunction involving a population of brain cells or neurons that communicate abnormally with each other. So it's not as if one cell's abnormal or one cell is causing the problem. It's a question of communication across a population of neurons. How a seizure appears or how a seizure is experienced depends upon where that seizure is within the brain. And so that's the location. And this ultimately influences how the epilepsy impacts a person's life. And the location and how far the seizure spreads within the brain influences whether a person loses awareness or loses consciousness as part of the seizure. So seizures, as I said, typically last a few minutes, sometimes shorter, sometimes longer. Epilepsy is a condition in which a person has a predisposition to having seizures, that there's something that exists within the person's brain on an ongoing basis that puts them at risk for another seizure occurring. And so to have epilepsy, we typically think the person has to have at least one seizure, and one seizure that's not provoked based upon what that person has done or circumstances. And then also has an ongoing or enduring risk for additional seizures, not because of what they're doing, but because of the communication that exists between neurons in their brain. And epilepsy is not one condition. It's not one disease. It's really a combination of many different conditions and some syndromes being a constellation of certain clinical features that tend to go together. But there are other forms of epilepsy that don't fit into syndromes and are really more described based upon what happens during the seizure. So epilepsy is not rare. Over 3 million people in the US have epilepsy, over 50 million people worldwide. This puts the prevalence at just under 1% for most economically developed countries, and it's actually increasing in the United States with about 1% of the population having epilepsy. And about 200,000, maybe even more, maybe 250,000 more people are diagnosed with epilepsy each year, which hides within the fact that some people have epilepsy that goes away, and it's not necessarily a lifelong condition. And so it's not as if the 3.2 million is increased by 250,000 every year, because some people may have epilepsy that resolves, and that's the good news. Epilepsy causes seizures, and seizures can cause injury, and so one major toll of epilepsy is the need for emergency care or emergency room visits, emergency department, as it's abbreviated here as ED, with about 1 million seizure-related ER visits in the US per year. So it's a major toll Looking back at the difference between seizures and epilepsy, here's some numbers, and that is the risk of having a seizure at some point in your life after you're being born is about 10%. But the risk of having epilepsy at some point in your life is about 3%. So an important point from this is that most people who have a seizure do not have epilepsy. And that is important to recognize when hearing about whether a person's had a seizure. But epilepsy, I mean, a person who has a chronic disorder where there's a risk for seizures is common, and it's the fourth most common chronic neurologic disorder. And maybe to put this in a different framework, the estimates in the US, about a third of adults know somebody who has epilepsy. And so it's part of our day-to-day life, just not sometimes talked about so much. It can occur at any age, but the risk is most in the young child and the older adults, so younger than 2 years and older than 65 years. And some numbers are that about 326,000 people under age 15 and about 570,000 of those over 65, all within that 3.2 million that I described at the top of the slide. This is a description of epilepsy onset according to age from the Mayo Clinic, and it's across a series of several decades, ending in 1984, which happened to be when this data was gathered. And this curve has changed a little bit since then, with increasing numbers in the older adult. The rates in children have not decreased, but the rates in the older adult have increased simply because we as adults are living longer and surviving other neurologic illness, which puts us at risk for epilepsy. Because I'll get to this in a moment, that epilepsy is not one condition, as I said before, but many conditions that cause a change to the brain, an injury to the brain, or some effect on the brain can cause epilepsy. And as people survive cancer or heart disease, there might be changes to the brain that end up producing epilepsy because of that other illness. So this description on the slide goes through the types of seizures that can occur most predominantly in adults, because that's what we're going to talk about mostly. And it gets into one of the major divisions in thinking about seizures, and that's how they start. And whether they start in one region of one side of the brain, this is called a partial onset or a focal onset seizure, or whether they start apparently across both sides of the brain or both hemispheres. This is called generalized onset, which is not meant to say that it's everywhere. It's meaning in the sense of being generalized throughout, but more a question of, well, it's widely distributed. The terms you see on the slide refer to some terms that you know from maybe reading package inserts for medications or speaking to some doctors about complex partial seizures or simple partial seizures, but that jargon is being replaced. It's gradually going away with more intuitively understandable terms referring to whether the seizure has impaired awareness, or whether the seizure is causing movement, which is referred to as motor, or a sensation, or autonomic here refers to change inside the body, such as heart rate or a feeling in the abdomen from the stomach. And so it's more descriptive and less just of a label. The generalized onset seizures aren't all grand mal. Grand mal is an old term, 19th century term having to do with a full body convulsion, meaning a full body stiffening and shaking. And a tonic-clonic seizure matches what most people think of as a grand mal seizure. But generalized onset seizures can just be part of that, with spasms called tonus, or jerks called clonus, or falls called atonic. But they also give you an absence. An absence refers to a seizure which just produces what it sounds like, an absence of interaction, and doesn't have major movements associated with it. And so being generalized doesn't mean anything bigger in terms of the obvious nature of the seizure, but really refers to the EEG. And that's the subtitle on the slide, the importance of the EEG. Ultimately, the EEG, the test which has the wires on the scalp recording electrical rhythms, is critically important for many patients and doctors to understand what type of seizure is occurring, because it can give a better indication of whether the seizure is starting in one region and spreading, or starting across the hemispheres, much better than can be by hearing a story or experiencing the seizure. So just as some descriptions to make this more rooted in what might be concrete and not just a description. Focal seizures can just be experiences such as hallucination. It could be any hallucination of a taste or a smell. That's what gustatory and olfactory referred to, or vision, or hearing something. And it's a hallucination that people have insight into as being a hallucination. It's not a question of the person really believing something is there, but experiencing it, knowing that there's something wrong occurring, that there shouldn't be something there. It could also cause changes in one's ability to express oneself in the language, or to remember something, or produce a sense of a memory distortion, like deja vu. It can also produce sometimes movements such as jerks, but all of this is in the context of no impairment of mentation or consciousness. The person has insight, the person has ability to fully interact, the person has memory for what's going on. And so it's more of an experience that can be described in detail without a gap or a confusion. If the seizure spreads within the region of the brain where it starts, it's still focal, but it's extended to a larger volume of brain tissue, it may cause a change in mentation or a loss of consciousness. But more often, this is more of an impairment of awareness. It's more of a sense that the person is there, but not fully engaged. They might have incomplete memory of what's going on around them. They might have some difficulty communicating. Their ability to communicate might be abbreviated, which is just simple words. And it often is accompanied by meaningless movements, more like grasping or pulling, or sometimes of the mouth. And these are called automatisms. The person also may wander, and there's usually a period of some memory impairment during it, but it's sometimes hard to know because the area that, so the time that the person is not aware of their memory problem is a time that they can't recall and describe later on, usually lasting a few minutes. And then the seizure may progress for some people, not always, into what is more of the obvious loss of consciousness, meaning a collapse with uncontrolled movements, sort of that large convulsion that I described earlier. And this can produce injury or loss of urine, blood in the mouth because of biting the tongue. And you may last the same duration as the other seizure, but much more obvious. And it's sometimes this seizure that leads the person to seek medical care because the other seizures may have been overlooked, not really recognized for what they were. So how do these seizure types match up across a population? And one part of the slide that's not obvious is that a person can have more than one seizure type. A person may have seizures that are just the warning or that awareness is intact, sensation sometimes. And other times a seizure may progress and cause impaired awareness. And other times it may progress even further and cause a bilateral tonic-clonic seizure, that convulsion. This description is more a question of what the seizures are when they occur. And if you look at a large population of people who have seizures, these are the seizures that occur, are represented in that population, with each person maybe having more than one type. But just giving a sense that focal is more common than generalized onset. And for the generalized onset, sometimes the seizures occur in what's called idiopathic. It's a medical term referring to the seizures being not due to a brain injury, or what I'm putting down as not idiopathic, as a generalized epilepsy that is due to some type of brain injury, but causing a diffuse or widespread change. Each of the seizure types can develop for the first time in the adult, or they develop in a child, especially after infancy, and then continue into the adult years. And so when we talk about adult epilepsy, I'm including both individuals who have the first seizure as an adult, as well as those who may have had them as a child and then never had a period where they resolved or went away and then became adults. How do we diagnose epilepsy? I put the word history in all capitals because ultimately this is the most important part. You heard the description of what makes it epilepsy is an intrinsic risk for seizures and the occurrence of seizures. And so a description of the episodes that might be seizures that is sufficient to make a doctor confident that a seizure occurred becomes important. And then it's a question then of whether other episodes have occurred, meaning more than one. There's no diagnostic test that says the person's at risk other than the story, the description, the history that the seizures have occurred. And so getting a detailed narrative and understanding a person's risk for seizures based on lifestyle or injury ultimately becomes the most important part of the diagnosis, and sometimes is the entire diagnosis. In other words, a person can be diagnosed with epilepsy based only on the history and with normal tests otherwise. And this is not rare. when a person is being evaluated, it's important for that person to have a neurologic exam and have routine blood tests. But also what's important is a brain MRI, a scan of the brain, providing detailed visualization of the anatomy. An MRI provides much more detail than a CAT scan or a CT scan, in other words. And so brain MRI is important. And also the EEG, the electroencephalogram, which is a recording of brain waves, the electrical fields around the head produced by the brain, because irregularities in these waves are an indicator of risk for seizures. So the MRI gives a sense of whether there's something structurally concerning about the brain that can cause seizures, and the EEG produces evidence of whether there's an electrical or functional change. In some ways, it's the difference between hardware and software, if you want to think in a computer sense, but the brain's not a computer. Just give a description. This is an EEG recording of a focal seizure, and you can see how it starts about halfway through the page as this emerging rhythm that becomes very regular, and it continues toward the end of the page. Whereas a generalized onset seizure, you can see it's starting across the entire page at one time. Each of these lines, I'll go back to the prior seizure again, each of these lines reflects a different location on the scalp. And so this one's starting in one region, although on the page, the regions don't look like they're next to each other, but in the scalp, I can tell you from the labels, they are in fact next to each other. Whereas in this case, it's starting more diffusely or across both hemispheres of the brain simultaneously. And this is relevant because this ends up leading us to thinking about different treatments as being more or less effective for that patient. And an example of the MRI, this is a face-on view of a brain, and this demonstrates an abnormality that is commonly present with epilepsy, and it's relatively small. And I believe you can see my cursor on the screen. I'm circling it right now, but it's the area of brighter signal there in the lower part off to the side. And it's not dramatic looking. And I think this is important to realize because it's not as if the type of abnormality that's present to the brain has to be something obvious or large to cause a seizure. It simply has to be electrically irritating enough to allow for that abnormal rhythm to develop. And then that rhythm continues forward to produce the seizure. So I'm going to describe a common form of adult epilepsy to give you a sense of what might be the course for that person. This is mesial temporal epilepsy, and it often is in the context of a person who's had some type of brain injury before they were 5 years old. Not always, but it happens. Or they had convulsions with fevers in early childhood. It's called a febrile convulsion. Or maybe you have a family history. Somebody else in the family who's had seizures or epilepsy. And so there's that backdrop, which is considered not a necessary cause for epilepsy. People can have this and not have epilepsy, but it raises the risk. And then when you see that in the story, you have a better sense of what's the problem. The seizures typically start in mid to late childhood. So it's a childhood onset, but often are not recognized until the teen years because the seizures might be subtle. They might just be an experience, and children have experiences, and often they get overlooked by adults. And it may not be until after the adolescence and early adulthood where the first recognized seizure occurs. And it's a matter of tracing back the experience that the person realizes, wait, I had this when I was in middle school, for example. Seizures can often follow warnings, or auras in this case, that go to where the seizures arise. These can be a sense of deja vu or fear or a rising sensation in the chest. And the seizures typically occur as focal with impaired awareness, what's described here as complex partial, using the old terminology. Often there's initial response to treatment. Medications work, but medications don't necessarily work indefinitely, and that can be a problem where the person may have seizure freedom for a few years and then the seizures come back. And there can be problems with mood. This form of epilepsy is associated with depression, which doesn't mean that everyone who has this epilepsy has depression, but it means that depression goes along with it. And it's not entirely because of the struggle of dealing with epilepsy, but also because the areas that are involved in causing the seizures are ones that are important for mood regulation. And so the dysfunction that's causing the epilepsy also can cause a change in mood and make life a struggle beyond the seizures. And the EEG and the MRI show the regions I just showed you in terms of problems, and cognitive testing, what's called neuropsychological testing, can show particular weaknesses in memory that refer to that one region in the brain. We can do cognitive testing that indicate what type of memory problem is present and whether it has the same location in the brain as where we think the seizures are occurring. So that's a description of epilepsy, but it doesn't really get to the question of cause. And I did say that there are numerous causes, and these causes really differ across different ages. And so this is a graph from a medical student textbook pointing out what type of seizures or epilepsies occur at different ages. And so there's partly genetic. And so about 6% of children of a person with epilepsy will have epilepsy, which means that 94% from this estimate of people who are born to somebody with epilepsy do not have epilepsy. And so you get a sense that there is some genetics, but not a very strong overall. Of course, there are exceptions. When a person has intellectual disability, the risk for epilepsy is increased, and about a quarter have this. By intellectual disability, I mean learning impairments that are more diffuse and what at one time was called mental retardation. And this really goes to the fact that the problems causing the difficulty with language and learning are also creating a situation in which a seizure risk is increased. If a person has a stroke or develops Alzheimer's disease, there's also increased for seizures or epilepsy from this because of the brain injury. And so you can see the causes really vary with the age. On the graph, you see that trauma, meaning serious head trauma, the type that often can cause a skull fracture, occurs in young adulthood. So you think about that as a common cause in that age range, whereas infection, which tends to be more often in the younger child, especially in countries like ours, tends to be an earlier onset for epilepsy. Then we put it all together and think about the epilepsy diagnosis. And we think about the seizure type, whether it's focal, generalized, or we can't say. We think about the cause, which is in medical parlance etiology, and that can influence our understanding as to what form of epilepsy it is. And sometimes it can lead to a syndrome, which would be a form of epilepsy where we have a pretty good understanding as to the collection of features that are present. And also often, but not always, which medications might be best for that epilepsy. Many people, and in fact, I would say most people with epilepsy do not have an epilepsy that can be characterized as a syndrome. And so we end up with more of a description of the type before that. And one of the major research aspirations we have is to get a better understanding as to what's causing the epilepsy and how to predict what's going to work best for that treatment by pinning down the diagnosis to a more exact diagnosis. So when a person has seizures, and epilepsy as well, but especially if the seizures are occurring, meaning the person's epilepsy is not fully responding to medication, there are consequences. And one is social stigma. Epilepsy has a history of stigma going back millennia. Early history describes concerns about epilepsy and seizures and fears. But it can also have an impact on quality of life. And this is a matter of restrictions from activities that one would want to do, but because of the seizure risk would not be safe. With this also is a question of disability or underemployment. A person can't engage in the workplace the way they would want to because of the seizure risk. When seizures occur in young children, it can affect their brain development and then have a toll in their brain function going forward. And this is for certain forms of epilepsy, but speaks to the importance of getting seizure control early on. Then there's a risk of injury and death, and the deaths can be related to the seizure or the circumstances of the seizure. Deaths from seizures in the United States are scary in number, with approximately the same number of people dying from seizures in the US each year as who die from prostate cancer or from breast cancer. And so a lot of these are seizures that are triggered by circumstance and not necessarily epilepsy, but it still speaks to the concern about seizures. I took this quote from a book that I actually got when I was in training. It's a collection of stories of people with epilepsy about their experience. And so it's called the Brainstorm Series. And this quote registered with me at the time, and still does, because of the recognition that it's not just the seizure causing the loss of consciousness or the potential injury, but also the lack of predictability for when the seizure occurs. That not knowing when it's going to occur has an extra layer of fear and concern, justifiable concern. And maybe part of that is what leads to the stigma or the reaction of other people, in that the other people don't know when to be concerned, and that can prompt part of the social reaction to epilepsy. So when do we treat? I mean, it should seem obvious, but when you think about it, there are elements to it that are not. And one is, well, I guess maybe fundamentally, we treat to prevent the occurrence of additional seizures. And this could be in somebody who's never had a seizure. Let's say they're in the ICU after a very serious brain injury, and we know that because of this injury, they're at high risk for a seizure over the next few days or weeks. And that would be what's called primary prevention, occurring before, but it's a person who's at risk for seizures. Or a person who's diagnosed with epilepsy, and that we know because of the seizures that have occurred, that they can have additional seizures. And so it's a point of reducing the likelihood of seizures. The reality is that treatment does not change the epilepsy. We don't have a treatment so far that reduces the likelihood of developing epilepsy in somebody who has an injury, or treatment that will reduce or reverse the process that caused the epilepsy in somebody who already has evident epilepsy. And so many people have heard of anti-epilepsy drugs, AEDs has been the abbreviation, but this has shifted in recent years to a new abbreviation of anti-seizure medications, making us a little more honest as to what the medication can do. Controlling seizures, of course, is critical. It would be nice to be able to alter the epilepsy separate from that. I said earlier that treatment starts after a seizure has occurred, and typically after 2 seizures have occurred. So why is that? And it's a very simple answer, that the person who has 1 seizure has about a 33% chance of having another seizure. And the seizure usually in the first year. This maybe reflects the numbers earlier that most people who have a seizure do not have epilepsy. So you can say that a third of people who have a seizure, a single seizure, have epilepsy, the others do not, and we wouldn't want to treat somebody for a condition they don't have. The risk shifts when a person has a second seizure or a third seizure, where the risk of additional seizures becomes about 3/4. This is considered a high enough risk where treatment is justifiable, because we don't want those other seizures to occur, and they are likely to occur according to overall population numbers. What happens if you start treatment and the person becomes seizure-free? Well, that's the problem you want to have, only because it's better to have that problem than to have seizures while you're on treatment. But the problem is that we can't easily say whether the person's seizure-free because the medication is doing its job, or because maybe the problem went away. Maybe the problem is no longer producing a risk for a seizure, and so the person no longer needs treatment. And so this has been a real issue, and I wish I could provide more guidance to many patients in this than I can, but we just don't have means to predict better. We know that about half of people who are seizure-free for more than 2 years, who come off medications, will have seizure recurrence. And some of these will be during the tapering, and some of these will be after that, years after. And although some people who've been seizure-free for 2 years will still have a seizure. And so that has to be part of the comparison. We also know that about 30% of people who have epilepsy appear not to need to be on medication anymore. They've had spontaneous remission. That is, the epilepsy has gone away, but we just can't know it. It's not that we don't know it, it's we can't know it because we don't have that test. And so it's a matter of the person who's been seizure-free on medication thinking about the risks of a seizure and what the consequences of that seizure would be, and the risks of staying on medication, and what their experiences of medication, and finding a way to a decision that should be considered one way or the other, but doesn't always have an obvious answer, or let's say an answer that's not universal for everyone. We know that the risk of a seizure after discontinuing treatment depends upon some features, and that the risk is decreased the longer the person's seizure-free, whether they're 3 years, 5 years, or even 10 years seizure-free, the risk drops off. We also know that when certain seizures occur, the seizures that are listed here, or when medications don't initially work, or requirement of more than one medication, there is a greater risk of seizures coming back after stopping treatment. It's hard to quantify this, but it fits into the decision-making when discussing whether treatment should be continued or not. This pie chart is shown in, I'm going to say, almost all introductory lectures about epilepsy. And it's from one study, which the study has been replicated, and shows how well do medications work. And when a person is diagnosed with epilepsy, about half, you see here 47%, become seizure-free. And if that medication didn't work, the chance of the next medication working is about, well, it's 13% of the whole, or about a quarter of those who are left become seizure-free. And if that second medication fails, the third medication has a smaller chance. And ultimately, if 3 medications have failed to produce seizure freedom, then the chance of getting seizure freedom becomes small, becomes a few percent. Doesn't mean it can't happen. And this is seizure freedom, not seizure improvement. So that's a reason to continue treatment and continue trying options. But it's a reality that's frustrating and brings us to think about other treatments besides medications for some patients. We can predict the likelihood of seizure freedom somewhat based upon the cause or etiology. And those people who have the idiopathic generalized epilepsy are mostly seizure-free. That's good. We can tell that often at the beginning, at the time when we start treatment, by looking at the MRI and looking at the EEG. When the seizures are due to a structural change, the likelihood is less, and certain structural changes produce even lower rates of seizure freedom. And so this is useful when planning and knowing for how long to watch. Ultimately, whatever happens is going to happen, and that's more important than any prediction. But knowing what level of concern to have can be helpful in terms of planning treatment and interpreting response to treatment. SUDEP has been received a lot of attention in the past few years, and SUDEP is an acronym for sudden unexpected death related to epilepsy. And this is a sudden death, meaning a death that's not related to an immediate precipitating factor like an injury or drowning. And it's also not related to a prolonged seizure, which is called status epilepticus. It's not unexplained anymore. The old acronym, letter U, is unexplained because we now have much better understanding as to what the mechanisms are that can produce SUDEP. But it's still present, and it's present disproportionately in those who are not seizure-free, especially those who have tonic-clonic seizures, and especially those who have seizures during sleep and require more advanced treatment. The risk is mostly in the middle adult years, and that's brings the tragedy to even be higher because these are people who may have had many, many decades of productive life in front of them, but have this maybe seizure related after a seizure or independent of a seizure, sudden death. Well, there are 2 things that a person can do to reduce the risk of SUDEP. One is to minimize their seizure frequency, which means striving for better seizure control with changing of medications or other options. And the other is if they are having nocturnal seizures, seizures during sleep, to not sleep face down, which is prone. Sleeping on one's back is much safer because part of the SUDEP occurrence may be in part blocking of the airway by the pillow. If a person has had a seizure, the seizure is over, but the person is not fully awake and the pillow blocks the airway in combination with what may be a decreased drive to breathe at that point as well. The question is, what's the mechanism for that decreased drive to breathe? The question I receive, well, pretty regularly is about blood tests for medications and what the blood level should be, because many of the older medications had an expectation for checking blood levels. But even for these older medications, where it's true more often than the newer ones, the range was not a goal, meaning the goal is seizure freedom and the goal is no medication side effects. And if the medication is reliable in producing both of these and the level is not in that range, that's still okay. And so the range is more of a target. It comes from a large population of people who have seizures, and it provides information about what typically works and what's typically not causing problems. But we're all different. And so that individual aspect is not captured by the range. And that range is not a matter of danger or toxicity, nor is it a measure of needing to be in a certain number in order to have seizure control. But it's useful for some medications, maybe more than others. And it, moreover, can be useful to establish a personal reference, a benchmark for the person as to what works for them. And so in many ways, getting the level when things are going well is more important than getting it when things are not going well, because you can have that as a point of reference later on. Sometimes it's not obvious to do testing when things are good. And it can help verify the medication is being absorbed and, getting to the person as expected. Medications don't just start and stop with the pill. And so some people get the impression that take the pill, medication works right away, and the next day the medication is gone. But really it's a matter of thinking about maybe a bathtub with a slow drip and a leaky drain, where that slow drip is putting more water into the tub, and the leaky drain is letting water out. And that's really what's happening, and that level in the bathtub is the medication level. And so it takes some time for the medication level to build up, thinking about that drain, of course, being in the end equal to the drip, but initially allowing for accumulation. And going up and down according to when the water is coming in or when the pill is being taken. And so ultimately, medication levels will vary between each dose. The peak will occur after the dose and the trough will occur just before the next dose. And that variation is the place we want the person to be protected from seizures and not having side effects. And so sometimes the decision-making for treatment is not just which medication to use, but how to use it, when to use it, what the dosing should be, and what's the duration of effect of the medication, and whether that matches the person's lifestyle in a way that is easy for them. Another important element in medication selection for the adult, but not just the adult with childbearing potential, is the effect of the anti-seizure medications on pregnancy. We do not have a medication for seizures that's proven safe completely, but we have a lot of data that shows differences in the medications in some that have relatively lower risk. And so you can see the red dot at the very bottom, which is called external control, shows the number of individuals, or what's the risk of some type of malformation in the baby born to a mother in the general population. The internal control is the risk of people who are part of the study who are not on anti-seizure medications, otherwise healthy individuals. So you can see rates of about 1% or so where there's a problem, and that's the sad reality. At the top of the chart, and these are the most recent numbers available, you can see that some medications have lower risk. The first three, where the risk maybe is around 2%. It's 2% of the total. Others have lower numbers, but the bars going left to right indicate the uncertainty. There's a measurement, which is the red dot, but then that measurement has to be considered in how reliable is that number. And the bars indicate being 95% sure that the actual red dot, not the measured one, but the truth is in that range. And so it takes a lot of pregnancies to really know this, and this comes from women volunteering during pregnancy to have the outcome of the pregnancy, their child included in this study. And so we can make decisions that have relatively lower risk. Other than malformations, and malformations, just to be more clear, can be things like hair lip or an abnormality to the heart or abnormality to the fingernails. And so the range of malformations, of course, are really broad and include quite different problems in terms of the meaning to life. In other words, a spinal cord abnormality is, of course, much more concerning than a fingernail abnormality. Separate from these malformations, there's also risk from autism, particularly for valproate, which is one medication that you can see has a higher risk for malformation. And the abbreviations you see there with the three letters are different medications that were included. I'm just putting there's context, and they are oxcarbazepine, carbamazepine, lamotrigine, and clonazepam. Valproate also produces an 8-point reduction typically in IQ. And 8 points is not a difference that people necessarily can know by meeting the person, but in the population, it's there. And so it's not that valproate is causing intellectual disability, but it is having an impact. And so it's another reason to move away from it and think more about carbamazepine, lamotrigine, or phenytoin in this case, as a way of not necessarily changing the child's IQ based upon the exposure during pregnancy. When a woman is pregnant and has epilepsy, of course, it's a choice to enroll in the study and provide the information. And what I say is that 2 reasons to join, because it's not going to help her during that pregnancy. But the reasons to join is it's maybe a matter of paying back or paying forward, because the decisions we make for that pregnancy come from this study. And so it's a matter of paying back to the study with more information, the fact that you've gained something in terms of decision making for it. But it's also maybe a little bit beneficial personally, because if that woman is thinking about another pregnancy in the future, it's contributing just a little bit of data that can help make those error bars smaller and make the decision making for any future pregnancy maybe a little bit easier. And I'm going to finish up with the idea about consultation with an epilepsy center. Because most people with epilepsy do not go to an epilepsy center. Most people, fortunately, do not need to go to an epilepsy center. Many people with epilepsy don't even see a neurologist. They have their medications refilled by their primary care doctor. But this is shifting in terms of more neurologists being involved. And the question is, when to go to an epilepsy center? And so ultimately, it really comes down to when treatment's not working. And if treatment's not working, the question is it the right medication? Is it the right diagnosis? Is there something else that needs to be done? Is there a change in dosing? There's so many different ways that treatment can be changed. And if it's not working, the epilepsy center provides the subspecialty care that's helpful toward thinking of different options. And this could be surgery. No one wants to get surgery, but surgery is an option for some people. These also might be devices, electrical devices, electronic devices that can help reduce seizure frequency for some individuals. But for some people, it could be that the diagnosis is not accurate, that the testing that's been done so far just wasn't what was needed to reach an accurate diagnosis. And so epilepsy centers have the means to provide more accurate diagnoses that can allow for more accurate treatments. And sometimes people are seizure-free, but the treatment itself is causing problems. And so it can be a matter of rethinking other treatment options that have low risk for allowing seizures, but also provide better tolerability for the treatment. So this is my second to last slide. This is my last slide, I forgot, which is the last one is maybe the most important, and to level set everyone's understanding of first aid for a seizure. What's important at the beginning is to remember that seizures usually end within a couple of minutes. I said this at the beginning of the talk. And so in a couple of minutes, it's very hard to do anything other than protect the person from injury. But protecting the person from injury is really the most important thing, because the circumstances of the seizure and that injury are usually the cause of need for higher level of care. And so it's a matter of looking around the person to see what's around them that could be a problem, loosening clothing if you can, giving the person space as the seizure resolves to come back to normal self. Knowing how long the seizure lasted is important. And so along with protecting the person from their circumstances, noting the time would be very important, because it's really hard to estimate time, even in a normal situation. In a crisis situation like this, a scary situation like this, estimating time is, I think it's impossible for anyone, including a medical professional. And so noting the time and then looking at the time when the seizure ends, when the convulsion stops, the person begins to clear mentally, is important. Because if a seizure extends longer than typical for that person, that could be a reason to seek a higher level of care, calling paramedics. When the seizure ends and the seizure was a full body convulsion, turning the person on their side can be helpful to help allow any fluids inside the mouth to drain out and not have them inhale them into the lungs. And so for the person who has a seizure and never had a seizure before, it's important for them to have urgent medical attention, because the question is, why did that seizure occur, and whether that cause requires treatment for itself. Was there something acutely occurring in the brain that requires treatment? If the person has a lot of seizures that are unusual for them, or a prolonged seizure that's unusual for them, that's another reason for emergency care or for rescue medication, which are now available. Or if the person has a complex medical situation which might be interfering with their recovery, or an injury related to this. But overall, it's best not to put anything in the mouth, because that just produces a foreign object in the mouth that can cause more injury. And it's best not to try to restrain the person unless they're in immediate danger, because the person having a seizure is not going to understand why they're being restrained, and like any of us, will fight back as a way of trying to protect themselves from someone holding them down inexplicably. So that was my last slide. This is UCLA. The pinkish building is the Neurology Building, and this is pictures taken from the hospital courtyard. So you can actually see my office in that pink building under one of the leaves. And I appreciate your interest. I'm here for questions through the chat or otherwise. And hope you're enjoying this Epilepsy Expo, as it provides a valuable service for people in our region and beyond. Thank you.
I have a question. You were talking
Yes.
about the febrile epilepsy and like different seizures and like the cause of them. I know right now we don't really have an answer, and I know it's unlikely to get an answer for some people. But are you aware of anything about like high temperatures as a kid can result in it, like temperatures above 105? I was known for that as a baby and a younger kid. Do you have any connections of that or know of any relations?
So high temperature by itself is not as concerning for causing epilepsy as a high temperature related to an infection in or around the brain. And so for an infant or a toddler who has really high temperature, who shows some neurologic abnormality, that's why urgent care is obtained. The seizures that occur with fevers don't necessarily depend upon how high the fever is, but more a vulnerability that's implicit to them for the seizure. And this can be genetic, and most kids who have this never have seizures afterward. It's something that's really limited just to their first few years of life, and then they go on without any additional seizures. And so part of this relates to the fact that anyone can have a seizure. Maybe they go into the group that I described, but most people who have a seizure don't have epilepsy. And sometimes that seizure is provoked by circumstance. And for those individuals, it's the fever that's provoking it, but thankfully not causing any permanent injury.
Okay, thank you. Because my parents said I asked them before and because I go to UCLA and all of that stuff. So we went over like, oh, did you see this as a kid? Did you see that when she was a baby? And they never saw any convulsions of any sort. That's like, because when you mention like a febrile convulsion can turn into adult epilepsy as you grow older and stuff. Because all of a sudden, 9.5 years old, and I go up to my parents, and then, slurred speech incoherence, and I'm diagnosed with partial complex epilepsy of the temporal lobes. So that's why I was wondering if
Right.
if just the temperature can cause it, because they also said maybe hormones because of the way that my menstrual cycle happened as a kid. But
it can be multiple factors, but I wouldn't think a high temperature by itself is straightforwardly
okay. So
related.
it could just be multiple things combined.
Yeah.
I know that
Yeah.
all the doctors there said it's probably not going to get an answer. I just always love science, and I'm
Well,
interested in
Yeah.
a master's of science in biology and genetics.
So I wouldn't say that there's not going to be an answer, because to say there's not going to be an answer presumes we're not going to understand this better over the coming years, which I expect we will. And so really, I would frame it that we don't have an easy answer right now, but we can look forward to the future where maybe it'll become more clear.
Okay,
There was a
thank you.
question here. You're welcome. There's a question here about Jevons syndrome. And questions about me as an adult doctor, where that's a condition that often starts in childhood and does continue into adulthood. And so an interesting phenomenon within epilepsy care that may not be obvious is that the advances in these pediatric conditions occur in pediatrics. And so the pediatric neurologist can sometimes have a better insight into that condition at that time for their patients who they have. The patients who grow up and end up with an adult doctor, it's a matter of us learning from the pediatric neurologist what is most important to then translate care to them. And part of this is because in pediatric neurology, there are more of the syndromes for epilepsy than we have in adult epilepsy. And so I think the question had to do with pediatric journals and where the publications occur. And that's true, although the epilepsy journals tend to be both pediatric and adult. But I'm going to agree that often the adult neurologists learn from the pediatric neurologists about the pediatric epilepsy syndromes and then use that understanding for their adult patients. And the point, maybe there's a second part of this, is that with clarification of a syndrome and maybe a better understanding of how that syndrome produces the epilepsy, we can sometimes lead to better medication choices. DRAVET syndrome is an example of this, where the clarity was earlier in pediatric than in adult. And we now know for the adult patient who has this, we will make certain medication choices based upon that diagnosis. So thank you for the question. Any other questions before we finish up? Well, thank you, everyone. I wish you well, and hope you enjoy the other sessions in this expo also.